Hi, I'm Dr. Michael Himle, Associate Professor of Psychology at the University of Utah, and I'm here to talk about misconceptions or misunderstandings related to comprehensive behavioral intervention for tics, or CBIT. CBIT misconceptions. The first misconception about CBIT, which is the one that I hear the most, relates to what symptoms CBIT is and isn't designed to address. So CBIT stands for Comprehensive Behavioral Intervention for Tics, and the key there is on that last word, tics. CBIT is a set of behavioral techniques that are designed to teach patients and families specific skills that they can use to reduce the overall frequency, intensity, complexity, or appearance of tics so that they're not interfering so much with daily life. So the key there is that CBIT is designed to specifically address tics. We know that many individuals with tics and Tourette disorder also have what we call co-occurring or comorbid disorders like attention deficit hyperactivity disorder, depression, anxiety disorders, obsessive compulsive disorder, anger control problems. CBIT isn't designed to address those problems. Now, certainly if a person has anxiety that's related to having tics, for example, is worried about how someone else might respond to their tics or react to their tics, treating the tics might reduce the anxiety. But CBIT isn't specifically designed to address comorbid problems. There are good alternative treatment options for those, including medication or specific forms of cognitive behavior therapy, but CBIT doesn't address them directly. So it's important that families sit down with a knowledgeable care provider to carefully review which symptoms are causing the biggest problem, the treatment options that are available, and make an individualized plan for how to proceed with treatment. The second misconception related to CBIT is related to the potential for treatment side effects. To understand this concern, it's important to understand a little bit about how CBIT works. At the heart of CBIT is a set of procedures that we call habit reversal training. And habit reversal training is designed to teach the individual to be more aware of when they're ticking or when they're about to tic. We call that awareness training. And then to block or interrupt the tics, and we call that competing response training. Historically, some people have raised concerns that by increasing awareness of tics or by blocking tics, that we might have a paradoxical increase in tics after treatment is over, that the person might become more self-conscious or more self-aware of their tics, or that they might get frustrated and feel bad about themselves because they're so focused on their tics. We've actually studied this fairly extensively, and we actually find that those side effects are quite rare. And in fact, most people actually show an overall reduction in tic severity following habit reversal training and a sense of mastery about being able to better control their tics. The third misconception or misunderstanding of CBIT relates to the idea that we can treat tics and Tourette using a behavioral approach. This shouldn't be misunderstood to suggest that the person is ticking on purpose, ticking for attention, or ticking to get out of responsibilities. The idea behind a behavioral approach is that even though tics are involuntary, they can be managed using behavioral skills. So we need to do more research, but we think that by teaching individuals to control their tics using these behavioral techniques, we might actually be altering or counteracting the underlying dysfunction in the brain. CBIT Success. Unfortunately, we know that although many people can benefit from CBIT, it doesn't work for everyone. The best evidence for this comes from two recent large randomized controlled trials, one with children and one with adults, where patients received 8 weeks of CBIT or general supportive psychotherapy. In both trials, CBIT outperformed general psychotherapy, meaning that more people responded to CBIT than they did to general psychotherapy, but unfortunately not everyone responded. So in the child trial, we found that just over half of participants were rated as much improved or very much improved following CBIT. In the adult trial, we found that about 40% of patients were much improved or very much improved following treatment. We don't know exactly why some people don't respond to CBIT, and we certainly need to do more research to figure that out, but several factors seem related to treatment outcomes. The first is that treatment success seems to be related to how much time and practice people put into learning CBIT skills. The second is that within a clinical research study, treatment is delivered fairly inflexibly. In routine clinical practice, there's more room to tailor and individualize the treatment based on the individual patient's needs. And then finally, comorbidity, things like ADHD and depression, can actually interfere with CBIT, and so sometimes these need to be addressed before we start CBIT. CBIT Practice. CBIT requires a fair amount of work. We think about CBIT as a set of techniques designed to teach a specific set of skills for managing tics. And whenever you're learning a new skill, that requires some dedication and practice. So CBIT is usually delivered across about 8 to 10 sessions, sometimes fewer, sometimes a few more, depending on the individual symptoms. And each session usually lasts about an hour, and one tic is targeted each week. But most of the work actually takes place between sessions. That's the heart of the treatment. So I like to tell families that CBIT is a bit like physical therapy, where the therapist's job is to teach them a set of specific skills, and then the patient's job is to go home and practice those skills on a day-to-day basis. For more information, you can visit the Tourette Association website at tourette.org.